Good afternoon, everyone. Thank you for joining us for today's webinar, From Cell to Community, Supporting Individuals Reintegrating After Incarceration. During our presentation today, audio and visual capabilities will be turned off for attendees to limit distractions. We do encourage you to ask questions of our presenter. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. Click on Q&A, type your question, and hit send. We'll address these questions as time permits during the Q&A portion at the end of the presentation. We are offering CME, Social Work CE, and McBath credits for today's webinar. We'll have a slide up with information about obtaining these credits during the Q&A portion of the webinar. We will also email the continuing education credit information after the webinar today. My name is Katrina Hernandez, and I'm an engagement specialist with OPEN. The Overdose Prevention Engagement Network, OPEN, is a diverse team dedicated to improving lives and reducing harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery. With an overarching goal of developing transformative evidence-based solutions to reduce harm and stigma surrounding substance use, we work to support healthcare providers and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources. We offer on-call consultation services to connect prescribers to our addiction medicine experts who provide guidance for managing patients who have substance use disorders or complex pain and can answer both individual treatment and technical assistance questions. We offer expert-led education and training sessions. All of our webinars offer free CME, CEU, and McBath credits, and for prescribers, all our credits also qualify for the DEA required SUD training. We provide MOUD training for physicians, and this year we are incentivizing primary care providers with $250 to complete one of our MOUD trainings to encourage confidence and willingness to help expand access to MOUD treatment. To prevent new persistent opioid use, OPEN established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes after various acute care episodes and provide data to inform opioid prescribing. You can access more information about all of these services more directly using these QR codes or visiting our website. OPEN also provides tangible tools to reduce harms of opioid and substance use, and our hope is to disseminate resources to places that need it most. We encourage you to partner with us and apply for our programs. We offer a free library of evidence-based printable educational materials for both patients and providers. Patient education materials can be co-branded for free and are available in English, Spanish, and Arabic. Provider education supports best practice implementation for primary care, acute care, obstetrics, pediatrics, and dentistry. We provide safe medication storage and disposal options. We assist groups all across the state in hosting local medication take-back events. We fund implementation of permanent medication disposal boxes for qualifying applicants, and we provide charcoal disposal bags and medication lock bottles for healthcare and community distribution. For overdose rescue support, we fund implementation of naloxone vending machines and distribution boxes, and we offer naloxone administration trainings. These trainings are offered as live, virtual, or free online training courses. No planners, faculty, or others in control of content, either individually or as a group, have relevant financial relationships with ineligible companies. And with that, I will now turn it over to our presenters for today, Liza Hutchinson and Adam Grant.
I'm Liza Hutchinson, and I'm a family physician and addiction medicine physician. I work both at the University of Michigan and at Packard Health, which is a federally qualified health center. And in that context, run addiction support services and reentry care as related to this presentation, and then work with OPEN in various capacities. And I'm going to go ahead and let Adam share a little bit about who he is, and then we'll kind of walk you through how we're going to proceed for the next hour.
My name's Adam Grant. I'm the Chief Executive Officer. It's been a new title, Chief Executive Officer of A Brighter Way, an organization that does navigation for people who are formerly incarcerated. On a statewide basis, we have 2 offices right now, one in Lansing and one in Ypsilanti. And I also should give a shout out to Grand Valley State University because I'm also a fellow for them, helping to develop their internship program for their higher education and prison program.
Hey, Adam, one question. Does the slides look okay, or is there any box at the top right-hand side that kind of looks like grayed out or anything funky?
Nope, it looks good.
Looks good.
Okay, great. Thank you, Sarah. Fantastic. So that is us, and we are going to today try to talk for around 45 minutes. In a dream world, we would make this more conversational, but obviously in the webinar format, that's a little bit harder. But Katrina will be monitoring the question and answer area, and we will try to make sure we touch on all of those questions as we can at the end. So just a couple of things that, to me are really the highlights of this presentation and things that you'll see and hear as we go along. So first image over here on your left is from the Prison Creative Arts Project, which is based at University of Michigan, but does amazing work across Michigan with folks who are incarcerated, to be able to express themselves through art and create incredible images. So you will see those throughout the presentation. Adam is really my secret weapon, so he is gonna tell you what I think is most important for all of us to know as healthcare providers, social service providers, folks caring and supporting for people who've been incarcerated. And then you'll also see some pull-out quotes here in the dark blue. This is from some research that we conducted here along with Adam as one of our guides, working with individuals in the community who are in organizations supporting people returning from incarceration. So sort of reflecting on the experience of incarceration, how that impacts health, and how we as care providers can ideally do better and be more intentional. So there's some things you'll see as we proceed today. So a couple of our main objectives are, first, we're just going to kind of delve into sort of the problem of mass incarceration, again, which I think a lot of us know, but just to revisit it and really how big of a scope that problem is. Some of the impacts on individuals' health who have been or are incarcerated. And then really thinking more toward the return to the community period, which I'm going to presume is where the space where most of us here today are really working versus in the carceral setting. Thinking about health risks that have been associated with somebody's carceral exposure, how their exposure to incarceration may influence the ways that they interact and engage with the healthcare system. And then really what can we do as, either clinicians, social service providers, et cetera. I know we have sort of a broad multidisciplinary audience here. So we'll talk specifically about what healthcare providers can do, but also what we as a larger community can do as well. And generally what I am hoping is that, we will all leave today feeling that, there is a sense of urgency, but also some inspiration and empowerment to, really engage intentionally with people who have been involved in the carceral system and advocate for efforts to address those health disparities, whatever our care setting and whatever our professional discipline is. So the why, everybody's time is really important. You're all spending your lunch hour or probably multitasking while you listen to this, and we're so grateful that you're here. To me, this is really why we need to be here today. So first of all, mass incarceration, whether we know it or not, it affects all of our communities, our friends, our neighbors, our families. We know that, I'll go through kind of the numbers of people who are involved in the carceral system, but also growing evidence, first of all, of the number of people who have an immediate family member or someone in their immediate community who has been incarcerated, and in fact that there are negative health implications for people who have a family member who's been incarcerated, right? So the problem extends beyond just people who've individually been touched by incarceration out into their families and their communities. Also, folks who are involved in the justice system are very much already in our care settings, our clinical settings, right? Again, this is whether we know it or not, because we may not be asking and folks may not be telling us. But a study not long ago in an urban primary care practice reported that 40% of people there had a history of incarceration. And again, that is probably an underestimate, given that not everybody feels comfortable reporting that history for lots of good reasons. This is, a hugely, neglected and urgent community health need. I'm going to sort of go over what those inequities are. And again, there's something that all of us here can do differently that we can start doing today and tomorrow to hopefully change the course of these disparities a little bit. So just to think a little bit more about mass incarceration in the US as a whole. So lots of people involved in the carceral system, right? And here on the left is sort of just dividing out that there are different institutions involved here. So the great majority of folks are in some kind of prison, but there are state prisons, there are federal prisons, and then there are also folks who are in jails. And then there's also immigration detention, some other smaller subsets here. But kind of just in broad strokes, important here is that jail and prison, although some folks go between the two, they can have fairly different populations as well, and different kind of presenting issues from a healthcare standpoint and for reasons why folks are there. Prison tends to be longer courses of stay, although not always, where jails tend to be, folks in and out in several days, a couple of weeks. Again, speaking in broad terms. What's also important to know, right, is that because there is this sort of fragmented system, there's no one standardized system of regulations or oversight, whether that's for the carceral system itself or the healthcare system, as we'll go into. So it's really sort of a potpourri that's happening. Then on the right, we look over here, and this is just reminding us that not only do we have a lot of people currently incarcerated, but then we have people who are in community supervision, right? They're on probation, on parole, and that is actually a huge stamp. This is many more people who are still under this process of supervision, which can introduce some of its own challenges, specifically speaking about folks accessing healthcare and moving forward in their lives. So important to remember, it's not just the individuals who are currently incarcerated, but friends, family members, and then people who are on supervision. So really many, many people being touched by this system. Another way of just looking at, again, what is far beyond just incarceration itself. So on the left, right, we look at there's this relatively small number of folks who are currently incarcerated, but then a larger number who are formerly incarcerated, a larger number who've been convicted of a felony, many more who have some kind of criminal record, and then again, many more who have a family member or close community member who has been to prison or jail. 1 in 3 US adults has a criminal record, right? Again, so this has ramifications for employment, for health, for many elements of folks' lives. And 1 in 20 US adults in general has been incarcerated. This is a little snapshot of Michigan. Well, first of all, the United States generally, where we compare to the rest of the world. I don't think it will be news to anyone, but we sort of top the charts in the United States by far in terms of rates of incarceration. And then we can look here across all of the different states and sort of see where Michigan lands in terms of the amount of mass incarceration and as well as community supervision we have. So we're sort of in the upper tier as well here in Michigan.
The charts on the left-hand side. Don't forget, off the charts. They had they couldn't even create a chart the right size.
Yeah, so great point, Adam. Yep, very much off the charts. Another thing that is, I think, probably that we all know implicitly, but worth revisiting is the tremendous disparities that we see by racial category. So 1 in 3 Black American men will be incarcerated in the United States, which is just a number worth sitting with for a moment and really absorbing. Then if we see down on the left, this is looking at by reported sex as well as ethno-racial group. And just a few things to call out. Of course, we see that all those little red squares, males are, disproportionately impacted by the carceral system versus females. And then we also see that, of course, white individuals and then are sort of on the lower end of rates of incarceration or their lifetime risk. And then we see, of course, that Black Americans as well as AIAN, Hispanic, tend to be have much higher rates of incarceration. And then the graph on the right is just looking at, on the left, the US population and the representation of each of these groups within the US population, comparatively looking at the representation within correctional facilities. So again, we see that AIAN is much lower proportion of our general population, higher proportion while incarcerated, and then same Latino and Black Americans have quite a disparate representation in those settings. Then moving a little bit more toward thinking about sort of health conditions, so behavioral health and physical health conditions. We also see pretty tremendous disparities related to this as well. If we look at the reasons why people are in jail and prison, really important to note is that many people are in, especially in prisons and jails related to drug-related charges. So more than 2 in 5 people who are incarcerated for federal crimes are there for a drug offense. And then if we look on the right, this is looking at jails specifically, but people in jail are about 8 times more likely to have a substance use disorder than the general population. And again, that is probably an underestimate because most of this data comes from individual self-reporting And of course, when people go to jail or prison, there are, pretty solid reasons why someone might choose to not share that they are struggling with substance use. We also see a really high prevalence of mental health conditions. And I think, again, this is, very much an underestimate. But reported at least 56% have had any recent or prior history of mental health problems. A little less than that has actually gotten an official diagnosis of a mental health disorder. But then really importantly, only about 1 in 4 has actually gotten any kind of professional help while they were in prison. So again, we have a population with very high rates of these conditions, but very little actual treatment being administered while people are in these settings. I'm going to pass it to Adam for a moment to share just a little bit more about either from personal or colleague experience of what's it like dealing with behavioral health conditions while incarcerated.
I would also like to say that the space that a lot of people are going to be entering into, we do a lot of work with medical students, and it's slightly different than it was even 3, 4, 5 years ago. So they are doing better, inside of prisons with these things than they were previously. There is more treatment taking place. Nonetheless, behavioral health disorders during incarceration show up the same way they do out here, but at much higher rates. And it makes absolute sense that they would, because the general base rate of ACEs for people who are incarcerated are like 4 to 1. And also the fact that it is a traumatic environment. It is meant to be traumatic, and therefore it induces a lot of other behaviors that might have been hidden while in society. Post-incarceration syndrome is one of those things that a lot of times comes up afterwards. I've been home for 6.5 years. I did 27 years for a bank robbery. I absolutely did. I also did 2 years on a previous, and I did 1.5 years in the county. So I've had a taste of all the different kinds of incarceration, and I'm still getting therapy now because it takes bites out of you and you don't know where. I think the approach to this is simply one of healing as opposed to just one of fixing. And it seems like a minor it seems like a minor adjustment, but I think it is a huge adjustment, and it also involves the person themselves, not just an outside entity doing it for them or to them.
Thanks, Adam. So yes, so I think, again, we see the really high prevalence when people are entering, and then as Adam is speaking to, then further traumas typically added while people are inside, and again, oftentimes not getting any treatment while they are inside. Similarly, we see higher prevalence of many physical health conditions. And this is again sort of, we see racial disparities in the community with most of these particular medical conditions. So those, of course, follow folks inside. So we see, higher rates of cardiovascular disease, higher rates of asthma, COPD, diabetes, cirrhosis of the liver. And so those are across the board, more represented in carceral settings. And then this infographic on the right, I'll speak more to this study in a few moments. But again, just showing higher rates of various different conditions, and specifically this one calls out, infectious or communicable diseases such as HIV and hepatitis C, and the very high rates of substance use disorder as well. So people come in, higher prevalence of behavioral health conditions, mental health conditions, physical health conditions, and then they enter a place where it's one of the few places in the country where officially people all have access to healthcare. However, that comes with a lot of caveats. So the healthcare system in jails and prisons to decide how much.
Liza, we lost you for a second.
Oh,
You're back
no.
now, though.
Am I back?
You're back.
Where did you lose me?
I think probably at the beginning of the slide, maybe.
You went over the caveat, and then you were starting to go into some of the parts about, yes, you have access to healthcare, but.
Okay, let's try again. Sorry, this is telling me unstable internet connection. But so yes, lots of caveats, even though officially everybody can access healthcare while they are incarcerated. The system is privatized. So in, basic terms, that means every jail and prison, right, they have their entire budget of how they're going to run their jail or prison, and they have to decide what portion of that they're going to put toward healthcare. Right? So what does that mean? Typically, it means the goal is spend less on care, right? So that may mean less preventive care. That may mean really only tackling things when they are absolutely necessary to tackle, versus trying to prevent things that are occurring. So lots of disincentives for people to get all of the care that they would get within the community setting. There's also really no regulatory oversight or specific agreed upon standards of care at this point for carceral health. There are some standards that jails and prisons can choose to opt into, but it is not a requirement. There are also pretty significant co-pays for medical care. And in a moment, I can let Adam speak a little bit more to that as well. But it does become, people do actually have to pay money to see a medical provider. And typically people are not earning money or earning perhaps a very small amount of money while they are inside. And this infographic kind of shows down here just a little bit, an example of cost. So, it might be, people might have to pay a copay of $2, $3, $4 to see a medical provider, which of course, if we're out in the world, doesn't sound like a lot. However, if they have a job inside, right, they're earning like a few cents per hour. So this is actually a massive copay for people. So that might mean they have to choose whether they're gonna call their family or whether they're gonna buy food, or whether they are gonna try to seek healthcare. And then finally, important thinking about healthcare within the system is the Inmate Exclusion Act, which essentially means that if folks have active insurance, usually Medicaid, when they're out in the community, that does not apply while they're inside. So Medicaid typically does not cover any services while inside. So again, that is sort of that disincentive because of the privatized system while people are inside. And then this is again just one of the quotes that came from our research. You stop requesting the medical help because that's not what you would get if you were home, right? Again, so just people feeling like the standards really are not as high as they would be in the community setting because of this, the privatized system. So as we can imagine, we talked about what the healthcare system is like, but there are lots of other reasons that incarceration can actually worsen health. Trauma during incarceration, which Adam has mentioned, certainly exacerbates any behavioral health conditions, and it can exacerbate physical health conditions. If people do experience solitary confinement, this actually confers an immensely high suicide risk. So that, can again significantly worsen folks' behavioral health conditions. Really poor diet and nutrition. And on the next slide, I'm going to let Adam share a little bit more about what that looks like. If folks are using substances inside, now out in the community, we have more access to safer use resources or overdose prevention, such as naloxone. Some jails and prisons have access to those resources and some really do not. And further, as we saw during COVID, a lot of infectious disease spread, crowding. And so, it's really easy for, with the lack of the healthcare system in there, and then all of these compounding factors, we can really see people's health worsen while they're inside. Adam, tell us a little bit more about what's a normal day like in prison, especially how it might affect your health.
I mean, one of the ways that I kind of frame it is that it's a hyper-social environment with a lot of antisocial individuals. And it's not just the people who are incarcerated that have some of those tendencies. So imagine what that does to your body on a regular basis, the cortisol levels that you're running around with on a day-to-day basis. And then you're living on things like you see on the right hand of the slide, which that's actually a pretty good meal compared to what they actually give now, because they've slowly been stripping the nutritional value of meals away, slowly diminishing the caloric intake, and then you compensate with the store that you're able to buy every 2 weeks, and those are sugary, salt. They're all snack foods, which don't help at all. So you want to think about that coupled with overcrowding. You want to think about the idea of the regimen and the structure that people just kind of do what they're told. They don't there's no real way to research what the nutritional value is, what you're eating other than on the packages of the things that you're eating out of the store. It's boredom punctuated with extreme violence. And I explain that because of the fact that if you see those pictures on the left, look at those pretty close for a minute. Those are people stacked 3 high. Most facilities, at least that I was in, was designed for 1 person in a room or 4 people in a dorm, and all of them have been doubled. So the services that are available are meant for half as many people. The facilities are meant for half as many people. And they've also pushed people down in levels, which means people who would have been housed by themselves for a longer period of time for whatever threat they may have been to themselves or to someone else, they've been pushed into double, triple, and quadruple bunk situations. So it's hard for people to understand that you're trying to have pro-social interactions, you're trying to have positive relationships, which a lot of guys do. I'm not saying all of them are dysfunctional. I had some very good relationships with people while I was in there, but it is surrounded in the quagmire that is prison, and that is dysfunctional by nature, and very infantilizing. Because many choices that grown-ups are asked to make, people who are incarcerated not only aren't asked to make them, they don't get to make them. And then at some point in time, they're released and expected to make good decisions. And we'll talk about some of those, especially when it talks about your health care and things like that when you get out. Those are difficult things to do when you've never been able to do them before. You've never had an even relationship with your doctor. There's always this power dynamic, and there's always a security component to it. And a lot of times the staff, the nurses, the doctors will write tickets for something you've done or a question you've asked, or if you dared to be an advocate for yourself. So this is just kind of your daily environment. And in different states, it's different ways. So you don't know when you're getting out. Imagine going somewhere and your sentence is somewhere between 2 and 15 years. Imagine how the stress of that weighs on you too, not knowing which one of those years is actually going to be your opportunity and how much longer that daily existence is going to be your existence.
Thanks, Adam. It raises my cortisol just to listen to what it's like. So I can imagine actually being in that experience. So I think, taking all of that into consideration when we think now toward what is happening when people are coming out, right? And this is, again, where most of us are probably going to be interacting with folks. So again, if we think toward folks are going into jail and prison already usually with a more of a chronic disease burden than the rest of the population, they are in this carceral setting that Adam just described, so their health is often deteriorating. Also, all of those the social skills, the ability to navigate life, right? Those are also deteriorating, or at least not being encouraged. And then somebody is expected to suddenly come home, oftentimes released without knowing when that's going to happen, and just suddenly there they are. So now we're going to talk a little bit about that particular time period. And lots is always happening during this time period. And so I'm hoping, Adam, you can just walk us through like a typical day or a typical week. Like what are you doing when you first come out?
All the things. I mean, if you're not, it feels like it anyway, but you definitely have all the things. Depending on how long a person has been incarcerated, they're trying to catch up with family, with friends. They have to do things like they have to get their ID in order. They have to figure out their benefits because most of them are going to qualify for SNAP benefits. They're going to qualify for Medicaid. None of those things are taken care of before a person comes home. They're expected to take care of them. Oh, and you're expected to see your parole officer within 2 hours after release. So you have maybe enough time to stop and get something to eat, and then you have to stop and see them. Then you might even think about after that, in that next, few days after you've got your Medicaid in place, you have to find a primary care physician if you're actually thinking about that. And then you're going to be limited to who are Medicaid providers Got to get your driver's license. Many of the guys have never even had their driver's license before. So they have to go through the process of their learner's permit. They have to go through that period. Job hunt, shopping, because you don't come home with clothes. You still need some, basic necessities. One of the things that often happens with people when they first come home is they're just paralyzed by the number of choices that they have in front of them. When you're in prison, you've got 3 deodorants. You might have 5 different kinds of chips. The first time you walk down um, an aisle where there are deodorants and there are shampoos and things like that, people are overwhelmed by the smells, the color, and the number of choices. 6.5 years later, I still use the same deodorant that I used while I was incarcerated. It works. My wife doesn't have a reaction to it with her asthma, so it works. And a lot of times I will still, when somebody will order something, I'll say that sounds good to me, because looking at how many options are available sometimes is just too complicated. So all the things that she's got listed on here too, the trauma, the insurance reactivation, transportation, complex systems. Remember, they're coming from a system that it's not everything is done for them. Everything is systematized in a way that it makes sense. If I want to go to medical, I write a kite, and the medical department puts me on a call out for a day. I don't have to figure about transportation or where this doctor is located, because they're located in the same building in every facility that I go to. The process is the same. When you come out here, a lot more is being asked of you, but you take the remnants of that place into your relationships when you come out here.
Thanks, Adam. Yeah, and I think something that you've emphasized to me and that I see in so many patients, right, is oftentimes a lot of this navigation requires a lot of use of technology. And for folks who have been inside for a long time, you certainly didn't know how to use a smartphone 30 years ago before you went in. And so now almost everything requires, using something like a smartphone. So that alone can be another huge challenge that people face during this time period.
The opposite of a smartphone. When I went in, they had the brick. That does not imply that it's smart.
So thinking about, again, from the healthcare provider perspective, or if you are a service provider of some kind, and interacting with folks in this phase, just remembering this swirl of all of these different competing priorities that people are experiencing. So it's not surprising, given the high rate of disease before people go in, the setting that they're in for a long time, and then coming out during this time of chaos, that people are more likely to die and have health problems in that time period. And this is a study that came back out in 2007, but still is really one of the most important studies because it shined a light on just the extremely high rates of mortality in this time period. So people are 12 times more likely to die in the first 2 weeks after they release. And then if you look over on the right, people are 40 times more likely to die of an opioid overdose in the time after the release than the general population. So immensely challenging time for folks. And what feels really important to point out here, again, for us is a lot of healthcare providers or associated multidisciplinary health professionals. 4 out of 5 of these are really things that we can intervene on as long as we can get folks engaged in care, right? These are all things that we can help with. So for us to think about going forward, there's a lot of space for action here. So there is a lot we can do. It seems very overwhelming. But again, even if you are, not a specific healthcare professional on this call today, right, there's a lot of other stuff we can advocate for, right? Simplifying people getting their IDs, safe and accessible housing, helping people get affordable, healthy food, smoothing out the Medicaid activation process, helping people get employed, transportation programs, better educational opportunities, right? These are all things that we can advocate for even outside of the medical system per se, and these are going to improve people's health and well-being. Adam, tell us a little bit more about what's it like to actually go to the doctor when you finally leave prison.
Most people didn't have the best relationship with the healthcare system before they went in, but it gets compounded and probably is much worse when people, leave. That statement that we had about Bloody Mary, That was my statement. Because it's absolutely true. There's a lot, you don't have to, your bedside manner doesn't need to be the same when you're a doctor inside. As a matter of fact, it's expected not to be. There's expected to not be a connection. You're expected to be Joe Friday. But also, I mean, I hate to put it in this category, the majority of them in there are not, I don't know, they're not there for the right reasons anymore, or at least that's the way that it feels. So there's a lack of trust that goes on there. The longer a person is engaged in that system, the less trust that they're going to have. We don't know how to engage with medical staff when we're out here either. It's like I've described it as, like I said, I did 27 years. I didn't know how to engage with children because there are no children in prison. So normal interactions between men and children, men and women, or men and medical staff, or women in medical staff is just it's not natural. So we don't, our communication is limited. And I kind of what exemplifies that to me is a discussion that I have with my own doctor after I'd been home for about a year and a half. So let me say this first off. My first doctor was somebody who did take Medicaid, and their name was Dr. Seuss. And she was awesome, but still it was pretty cool to be able to say that I had Dr. Seuss. But Dr. Seuss went on to do something else. My career took me into other places, so I had other options too. So I got with a family doctor, Dr. Izo, and him and I were having a conversation, maybe the second or third time that I'd seen him. And he said, you know, how are things going? Any complaints? And I did what I typically did because of all of those years of incarceration. Nope, no complaints. And he immediately followed up with, you do know this is the complaint department. And it changed the way that I interacted with my own healthcare. It changed the way that I interacted with my doctor, that they can't help me if they don't know certain things exist, and they're there to help me. So before, while I was in prison, explaining what was going on with me didn't do any good because you'd get the same standard response. Early in my incarceration, the response to everything was stop smoking, drink more water, eat your greens. But I broke my ankle, you know, well, stop smoking, drink more water, and eat your greens. So understand that this is not a one-off. My story is not a one-off. My story is the vast majority. It is the rule, not the exception. So the majority of people that you're going to be working with are going to be dealing with these kind of traumas. If you're dealing with women who've been incarcerated, some of them have gone through labor in shackles, you know, and had the opposite sex in the room watching the entire, you know, procedure. There are a lot of things that have sown distrust, and rightfully so, you know, for those people who have been incarcerated. And so letting them know that you care, letting them know that you're not dictating and that they have a voice in their care is hugely important, and could literally save a life.
Thanks, Adam. I'm thinking about a patient I had recently who had been incarcerated for many years, and we worked together for about 6 months, and I saw him every month for substance use disorder treatment. And after about 6 months, he finally came in. He said, "You know what? I've been lying to you for the last 6 months." And it was an amazing moment for us, right? Because he explained that exact thing, that he said, you know, when you're in prison, if you say something's wrong or you make a complaint, right, you are punished for that. And so that was sort of a light bulb moment for me, and really echoes kind of what you're sharing, that the mistrust is very well founded from that setting. And then it's just helping people be able to learn that this is a different setting. And I think that's really, you know, our role and responsibility as healthcare providers, is understanding where people are coming from and then finding ways to build trust. So again, these are just some quotes from the research. Few providers have a shared identity with returning citizens or training on their unique needs. Some demonstrate discomfort during the interactions. Time constraints also further limit the ability to provide the holistic care that's needed. So that's real. The time is always a challenge. Most people coming home are so traumatized from their healthcare experience inside that they just try to avoid it as much as they can. So for all of us to file in our brains, if we're clinicians, that this is the background people are coming in with. So as we go through, our clinical interaction with a patient, these are some things to keep in mind, sort of for the history and for the exam. So thinking about our typical trauma-informed principles, but so vital here. So making sure people are physically comfortable. And again, that may not be what we think is comfortable, right? So I have a lot of patients who want the door wide open and they don't worry as much about the privacy, but being in a room with a closed door does not feel comfortable for them, right? So making sure we help people feel as comfortable as they can in our setting. Using, clear language, not a lot of medical jargon, again, person first language as much as we possibly can. Asking permission to ask questions, right? As Adam alluded to, most people are not used to feeling like they are, in control of anything, or they don't feel empowered to share certain information or not. So it's just, asking that permission. Letting people know why we're asking questions, right? We're so used to, as healthcare providers, asking pretty, in your business kinds of questions, and we're asking them for medical reasons, but people don't always understand why, we need to know about their sexual activity. So really just trying to make that clear for people, again, because there's pretty well-founded suspicion with people asking them detailed questions. And then I also think important, explain to people what you don't need to know, like the extreme details of their charges, right? And there's actually some good data that shows that when healthcare providers do know about the details of charges, especially if they've been violent, it does change the care that we provide. So not going into the details of that. I'm really trying to avoid asking about incarceration history on written forms. Of course, we love all those, those stacks of papers. I'm a primary care doc, our office, you come in, you get a giant stack of papers to fill out about yourself, and it is important information, but disclosing your incarceration on a form like that rightly feels pretty scary for most folks, so probably isn't going to yield very helpful information. Again, not asking about details of people's charges, trying to avoid language that, again, the individual may use about themselves, like I'm a felon, etc. But as healthcare providers, we want to use person first language. And then avoiding great details about somebody's incarceration in the EHR. And I'm going to talk a little bit more about documentation in a moment, so I'll expand there. Just a little bit, some ideas about how to ask about somebody's incarceration, right? So most of the time people aren't going to come and just tell you right away, right, that they have had that history. So it might take a little while to get to know somebody to explore this. But some of the ways that I try to ask about it is, again, kind of normalizing. So lots of my patients have, had their own experience with incarceration or their family. And I know that that affects their health. Like, has that happened to you or anybody in your family? Or if we learn that somebody does have an incarceration history, really helpful can be, again, I don't need to know about the details of your charges, but could you share with me the kinds of things that lead to incarceration for you? For example, some people find that they always end up in jail when they're using drugs or because of an activity that helps them get their basic needs met. Right. And so asking that question gives us helpful medical information, right? Because a lot of times people are landing there because of, complications of mental health or substance use, and those are things we can help with. And so we can learn that without asking the details of somebody's charges. And then sort of from that strengths perspective, tell me more about the times you've spent living in the community and what helped you stay out of prison or out of jail during that time. Again, those are things we may be able to build on in our care settings to help people stay out. And this is sort of just a way, there's a great podcast that I recommend, the Curbsider's Addiction Medicine podcast. But just sort of the comparing, if you're over time, again, trying to learn about somebody's incarceration history in a way that is medically useful, these are some of the things you might try to think about. And I compare it to a substance use disorder history. So mostly just trying to think about sort of, overall duration of exposure. Has somebody been in jail for one day versus were they incarcerated when they were 18 and now they've been in there for 30 years, right? Those are really different phenotypes, and that person's going to need different kinds of support. Are folks on community supervision? This can very much influence the way that people show up in healthcare and the stressors that they're facing and ways that we can advocate for them. And again, trying to get at what kinds of things lead people back to incarceration, because again, we can intervene on those oftentimes. Then when we are documenting, right, and this is getting trickier and trickier, right? A lot of people have DAX or they have some sort of AI transcription. So a lot ends up in the medical record, and we really need to be thoughtful about this, right? So there's excellent data around, various stigmatized identities and the ways that that shows up in the medical record. So being really cognizant of that. Only recording really relevant details. So again, especially if you're using AI and it's transcribing everything for you, if you happen to have somebody who does share a lot about their charges, going back and not including all of those details, knowing that that is going to change the care that they receive in the future. So recording medically relevant information. So what I would consider is, right, if somebody has just released, that date of release is important, right? Because we know that they're in this very high risk period. So medically, that's very relevant. Or specific social needs or things that get that person reincarcerated that we're going to address, including those pieces, but not irrelevant details that potentially may transmit stigma. And then sharing with the patient why you're documenting, what you're documenting. Again, a lot of people might assume you're, sitting there typing away a letter to their parole officer for all they know, right? And in the carceral setting, oftentimes there's a pretty murky line between the corrections team and the healthcare team, right? And so people don't understand when they come out that their medical information is private and protected. So providing some of that education can be helpful as well. Screening and treatment guidelines, there's no specific guideline. This is just, following typical standards for the general population and based on that person's risk factors. But I do, again, if time is pretty limited, just try to think quickly of if I have a person who has recently released, one of those like top 5 causes of death, do I make sure I'm screening and assessing for those things? And, things like infectious disease testing or preventive care that may have been missed or put off while people were incarcerated. That's kind of the place to focus. And then very, very, very important, because of that #1 cause of death being opioid overdose, finding out if people need medications for opiate use disorder. So there are now a number of excellent studies that have showed that, if meds, first of all, are started during incarceration, which is happening more and more often, we see a decrease in overdose, we see a decrease in all-cause mortality, we see a decrease in return to incarceration or recidivism, and then we also see that people are much more likely to continue on medication for opioid use disorder after release. And why that is so important is the mortality reduction from this medication is profound and is one of the most important tools we have in all of medicine. Decreases the risk of mortality by 50 to 60%, depending on the population you look at. So really prioritizing this if you do have somebody with opioid use disorder who has recently released, making sure that they're offered this treatment. And this is, again, I won't dive into this for time's sake, but more details on this excellent podcast about MOUD after release from incarceration. And then there's a lot we can do in the advocacy space, right? Even if that doesn't mean that we're like going to Lansing and advocating, right? But just a lot we can do with a patient in front of us. We can offer a letter of support to their probation or parole officer, making sure that we get a release of information and the patients know we are only sharing with a release signed. But that can go a long way, right? I do a lot of substance use disorder treatment. So if I write a letter that somebody has been, adhering to their plan of care, showing up for every month appointments for a year, that says a lot and can really make a big difference for someone. But if we don't know that someone's on probation or parole, we can't make that offer. So that's where that asking and that trust building really comes in.
I would add one to that too, Eliza, because
Yeah.
I think one aspect of advocacy that is often overlooked is simply the relationships that we have and proximity. So working with your fellow colleagues to talk about these ideas, to humanize people on the other side of it, and to remind them of why they got into the work to begin with, I think is a huge part of advocacy that sometimes goes overlooked.
Thank you. Yes, absolutely. Hugely important. And then just, if you happen to be working in an inpatient setting, a lot you can do. And I'm mostly just going to point folks to this amazing resource, Scopes and Shields, which gives a lot of tips about how to act with law enforcement in the inpatient setting, optimize patient privacy. Just important to remember that HIPAA still does apply. And sometimes when law enforcement is present, as a healthcare provider, it's hard to remember that. But law enforcement is not entitled to know everybody's medical information. So I encourage you to go to Scopes and Shields. And then I know we are just about at the end of our time, so I'm gonna kind of, I'll leave this one for now, but this is just lots of different recommendations that we can do from a system standpoint as well as a clinical care standpoint. And then I want to just end on the note of some of the care models that we can think about. So one that is very well known and is now in many states across the country is the Transitions Clinic Network. And really the important part of this model is there is a trained person with lived experience who is working and partnering with the healthcare providers to help build that bridge of trust, help people navigate systems, provide that relationship. And even if you are in a clinical setting and you don't have the funding or the ability to have somebody like this embedded, you can partner with organizations like Adams. And I'm going to let him share a little bit about that. But then that person can provide some of that peer support, even if you can't embed them in your own care system. So Adam, I'm gonna, if you can, in like 1 or 2 minutes, share a little bit about A Brighter Way, and then we'll make some time for questions.
We've taken a very conscious approach to it, and I can't say that everybody has, to this healthcare navigation piece, working with Eliza to develop, to train our staff. That's my crew right there. But it's not just that. There's a lot of things that, it takes time to develop rapport. It takes sometimes shared experiences for people, to be able to trust, on a level. And it also takes, pathfinders. And so those of us who have been out and who have navigated these systems before are pathfinders for others. I can share the Dr. Izo story and that they understand that. They understand where that's coming from. Eliza now has a story that she can share with people about it taking 6 months. So she can talk to somebody else about, let's not make it take 6 months. Let's shoot for 3. Let's shoot for 2. But working with people who are formerly incarcerated, the vast majority of us, when we come home, especially when we've done a considerable amount of time, it's funny that the stigmas often go in the opposite direction. If you've done a lot of time, people seem to be more afraid. But the majority of us come out very motivated to be positive members of our society, to help one another, to help the communities that we're a part of. So we consider it an honor when people ask us to help, when people ask our opinion, and we take it very seriously. So if there is not an organization in your area, or at least not one that you're aware of, please reach out to A Brighter Way, and we will do the research, because we have friends all over the state. There probably is somebody doing really good work in your area that you're not aware of. And if there isn't, A Brighter Way will work with you to do the best we can to help consult with the situation, connect with the person that we may need to connect with, however we can help. We're not the only ones. We're just the best.
And the humblest, but you guys are amazing, and I have learned so much from you. So with that, again, hoping that we have, shared a little bit about the state of how things are, but also left you with a lot of hope that there's a lot that we each can do in our corners. And we're happy to answer some questions. I will just leave our gratitude notes up here.
There was a lot of good questions in the chat today. So how can, hang on 1 second. Will you address why mental health meds are stopped and not allowed in our prisons, jails, even those diagnosed with seizures?
Great question. And that does happen sometimes. I think there are a lot of reasons for it. And I think just a couple to touch on are, first of all, sometimes patients don't even, know to let a healthcare provider know exactly what they're on. They may not even be aware. Secondly, again, it's just that lack of access to providers. Oftentimes, right, or there may be a big lag once people get in and it's finally sorted out that they actually have a medication they should be on. That can take a while as well. But officially, yes, people should be able to continue on mental health medications while they are incarcerated. But I think, again, the privatization of the system and the difficulty of the access are often a piece of that. Adam, I don't know if there's anything you want to add to that.
Are even more complicated. So they may be talking about jails, and jails are always security conscious and don't necessarily trust that the medication has the right packaging. So it's complicated.
What rights do incarcerated individuals have in terms of behavioral health care that we can advocate for and make sure are being honored?
Yeah. So go ahead, Adam.
I mean, I don't know about the rights. You have right to access. That's the same thing with medical care. You have the right to access. What access looks like, everybody knows you're supposed to get your teeth cleaned every 6 months out here, 4 months preferably, but at least every 6 months. In prison, you can ask for it once a year, and then it takes 6 more months. So in actuality, it's about once every 18 months. The same thing with behavioral health. With behavioral health, if you don't have a diagnosed condition, especially, you might be able to get a 15 minutes, report, and you don't really get a lot of help. I always tell the joke about I went to one. I was talking about how do I maintain a positive mind frame with all this time to do, and one of the books that she recommended was in French. I don't think I ever spoke French during that 15 minutes, but somehow, anyway.
Yeah, and I think, to your point there, people are entitled to healthcare, but because there are no specific regulations of like, what does access even mean, right? Like, is that a certain amount of time someone should be able to access a provider? There's nothing like that that is written down, unfortunately. So it leaves a lot of room for interpretation of what access means, unfortunately. Certainly if there's something that feels like sometimes, a family member or an advocate, like calling and calling and calling can eventually result in some change. So which again, it shouldn't take that, but sometimes a very proactive advocate reaching out can make a difference in a system that is really suboptimal.
We do have someone that raised their hand. So Lee, you should be able to unmute yourself and ask your question.
Still muted.
Yep, you're still muted. You should just be able to click your unmute. Okay. Well, so we'll take another question from that I pulled from the chat. This one was addressed to Adam. How can I help a person once they are back in the community and have to come to the emergency room where I work for emergency services?
Again, anytime that you can connect them with services like ours, I think that goes a long way, because a lot of our people are coming out and they are getting all their health care through emergency services because of the relationship that they have, or the lack thereof, with the healthcare system. I think the main thing is, again, just let them know that you care, let them know that there are options out there. And one of the things that always works well with ours is we don't work directly with probation and parole, and people find that to be endearing. It's not that we don't communicate with them. We do not share anybody's information unless they specifically ask us to. So connect them with a local organization that is peer based, if at all possible. And if you don't have somebody who's doing reentry work specifically, you're probably going to have somebody who's doing recovery work, and a lot of them are formerly incarcerated, just usually on smaller scales.
And I know we're at time. I wanted to just call out one quick thing that I saw in the chat, which is the 1115 waiver. And someone from out of state asked about it, and that is a really important part of this conversation. Michigan, so the 1115 waiver, for folks who don't know, is it's a waiver that would allow Medicaid to be turned back on while someone is still incarcerated, usually in the last 90 days. Ideally, getting them better health care, getting them connected to community care, and eliminating that gap where people are often not on any insurance when they present back in the community. So the answer is Michigan had one approved. However, the last I heard, there was no actual funding allocated for it, given budget difficulties. So there's not much action on it right now in Michigan, but I certainly hope that there will be again in the future. And a lot of states have been able to do that and have showed really improved outcomes doing that. So thank you for asking about that, and something for folks to pay attention to. Okay. Sorry.
With that, we are at time. I want to thank everyone again for joining us, and just remind everyone that if you did not get the continuing education credits, you will get that in an email, so you can apply for that. And I hope everyone has a good afternoon. Thank you again, Liza and Adam, for a great presentation.